a bit. Hi there, my name is Dr. John Hughes. Today I'm going to present on a multimodal regenerative approach to traumatic brain injury. This is for the OMED Virtual Conference, October 2020. Disclosure, the content of this presentation has been peer-reviewed for fair balance and evidence-based medicine. I have no relevant financial relationships to disclose. Hi there, my name is Dr. John Hughes again. I'm from Georgia originally. I'm a doctor of osteopathic medicine. I finished my training at the Arizona College of Osteopathic Medicine, 2007, studied family medicine, ended up studying for about a year afterwards some of the therapies I do today and started Aspen Integrative Medicine in 2009 near Aspen, Colorado, as well as TBI therapy in 2014. Today, we're going to learn the biochemical and metabolic effects from TBI, traumatic brain injury. We're going to understand specific hormonal reactions associated with TBI. And we're going to offer an osteopathic, integrative, regenerative, and multimodal approach to treating TBI. What happens in TBI? You get a headache, fatigue, ear ringing, disorientation, loss of mobility, seizures, loss of smell. Sometimes cognitively, you end up getting memory decline, inability to pay attention, loss of executive function, unable to plan, reason, solve, confusion. Psychologically, you end up getting irritability, frustration, tension, anxiety, apathy, and even suicidal thoughts, PTSD, and depression. The neurobiochemical cascade in TBI. We've talked about this last year. You guys have heard this. You get mechanical stress that disrupts cellular membranes. You get neuronal depolarization, firing and release of neurotransmitters. Increased extracellular glutamate. The potassium ion, which is usually very large inside the cell, goes out of the cell, and the calcium ions go intracellular. You get a hyperglycolytic response overall, and with these intracellular calcium ions going, into the cell, they get sequestered by mitochondria, causing a inhibition of oxidative metabolism. Ultimately, the energy demands must be met only by glycolysis. You get lactate accumulation and ultimately decreased ATP production. The cell enters a phase of metabolic suppression and widespread depression. Intracellular calcium ultimately causes apoptotic reactions and resulting death to the cells. And you get immediate decreases in magnesium 2+, which limits recovery. This is it in a diagram. You can see neuronal depolarization, and there's a big challenge here with this traumatic brain injury. The potassium is going outside the cell, and the calcium is starting to migrate in towards the cell and getting into the mitochondria and damaging it. That's really kind of the most important thing. Ultimately, brain injuries can lead to death and destruction of the sort of biochemical aspects. It's like the bomb has gone off in the laboratory of the brain. This disruption in the neurobiochemical cascade of traumatic brain injury ultimately leads to a patient's emotional, cognitive, and somatic symptoms. These symptoms are not just a mental health psychological issue, they're very much a neurobiological consequence. And ultimately, if we can treat this neurobiochemical injury, then we can potentially resolve patients' outcomes and improve their outcomes. There's treatments there's studies that have done this, and they've pre-treated animals before hitting them on the head, and with magnesium, which counteracts that intracellular calcium, and they've had better improved post-traumatic outcomes. So what else happens? You get a disproportional pro-inflammatory cytokine production and release, increased counter-regulatory hormones that work against the action of insulin. You get hypermetabolic and catabolic states, as well as impaired nitrogen homeostasis and oxidative stress. So ultimately, you have, from a hormonal and cytokine perspective, you have a real issue with managing the brain in its normal state of low inflammation. So you get a very inflamed brain, lots of cortisol that's in this hyper catabolic state, and unable to build and repair itself. There's impaired vascular function, impaired circulation, impaired energy metabolism, and damage to mitochondria and DNA. Other interesting things, serotonin, which we all know is a very important neurochemical neurotransmitter. You have ultimately decreased the protein levels that actually transport this serotonin into the brain. And we can see that in neuronal fibers, the mRNA, as well as the cerebral cortex. All of that means that there's less serotonin in the brains long-term with TBI and PTSD patients. Serotonin is also limited in its origin and rate-limiting steps by the RAFI nucleate neuron cell groups B1 through 9. And if these get damaged, then ultimately tryptophan cannot be converted to 5-HT, also known as serotonin, by its enzyme tryptophan hydroxylase 2. So damage these RAFI nuclear groups, which is seen largely in traumatic brain injuries. You end up dysregulating the ability of the brain to actually make serotonin. Serotonin, also known as 5-HT, regulates sleep, appetite, pain, and mood. 5-HT levels are also reduced in other conditions, as we've seen in the literature. Chronic stress reduces 5-HT, depression decreases 5-HT transport binding, which ultimately leads to the lower 5-HT. And without 5-HT floating around, you can't manage your fight or flight response. It's kind of like a secondary cortisol effect in some ways. It's not allowing the patients to handle stress. So lower serotonin means you have higher levels of depression, stress, and PTSD. What else happens with neurotransmitters? TBI increases at a longer term noradrenaline levels. So things like norepinephrine, epinephrine, increasing inflammation in the forebrain, increasing anxiety-like behavior in the fight or flight. You're running from the bear. It's like the brain gets stuck in this very anxious, like fear-based state. And you have that in combination with lower serotonin ultimately leads to a PTSD type state, internal anxiety, which is defined as internal anxiety with poor ability for the patient to cope. So very challenged in this level. What else happens? You get cholinergic excess, which amplifies destructive excitatory amino acids such as glutamate. You get a cerebral monoaminergic excess, and that leads to inability to long-term to have good cerebral glucose use and results in a metabolic crisis. What happens metabolically in a TBI is very simply summed up with a famous neurologist named Robert Cantu in 2013. He said the brain is in a metabolic crisis with concussion. Potassium ion is going from inside the cell, going extracellular, calcium ions going intracellular, and neurotransmitters widely released in a chaotic manner. And ultimately, it takes energy to pump that potassium back to put the neurotransmitters back on so the cell can function. Without energy, the brain doesn't heal. If you don't have energy going back in to help that brain heal, it's not going to heal. And the problem with a lot of treatment, they tell the patient to go home and rest, and their brain will heal. You'll have enough energy to function. The problem is the brain never rests. The brain's always working, even while we're sleeping. It's consuming 20% of the oxygen that we inhale and 25% of that glucose. And the brain has to decide, hey, do I function or do I rest? Or try to heal. And since its primary goal is to try to function, it has to decide, hey, even when I'm sleeping, I'm managing hormones, I'm managing the heart rate. Do I keep working, or do I try to help my brain heal? And that's why it's so hard to heal from a brain injury. You sprain your ankle, you rest it on the couch for 2 weeks, starts to feel better. You sprain your brain or you injure your brain, the brain never rests. So it's like walking on a sprained ankle or a broken ankle and still trying to heal that ankle. Head injury can damage also hormones in the brain, particularly the pituitary gland. There's been a lot written about this. Pituitary gland releases growth hormone, releasing hormone, and reduced production of growth hormone ultimately results in reduced interest in sex, fatigue, stamina. Not only you don't have enough energy, but you also don't have enough growth hormone to help you kind of maintain your desires in any part of life, sex, getting up out of bed. So 18% of people with brain injuries have this or more. I would say even a higher amount, especially with more moderate, more severe TBIs. Another part of the pituitary gland is the part that makes antidiuretic hormone, as we know, also known as vasopressin. Reduced production of ADH can cause diabetes insipidus, and that can mean excessive urination and extreme thirst. Unlike typical diabetes type 1 or 2, diabetes insipidus is not about blood sugar levels and it's not treated with insulin, but it can cause patients to get dehydrated. This occurs in about 25% of people with brain injury, and many have had severe TBI. This is a workup of neuroendocrine dysfunction, which can be caused and largely is the result of TBI. We talked a little bit about pituitary gonadal hormones, but this can include luteinizing hormone, FSH, testosterone, estradiol, and you can start to see challenges with these patients with traumatic brain injury. So growth hormones we talked about, there's challenges here as well. So that's another issue, and you can look at these charts to diagnose, hey, where's the deficiencies? Dr. Bill Clearman, one of my colleagues, teaches a course on all these hormones and how to help address them. So I would highly recommend getting a course on how to best treat with hormones, because it's not a very simple protocol on how to treat these hormonal deficits in traumatic brain injuries or any other condition that might be affected at the central nervous system level. Pituitary adrenal, that can also be affected, and you can look at cortisol levels as well. Pituitary thyroid, so the thyroid can be affected. Thyroid releasing hormone can be affected. Prolactin can be affected. So I mean, there's a lot of hormones that are affected, and learning how to treat these appropriately and not over treating can be very, very important. At the same time, very, very key to do this with caution. And a lot of times the brain does heal. Sometimes it's over a month you'll start to see these hormone levels bounce back in. I mean, I regularly check just a basic testosterone levels for males, and I often will find that after I do treatments for traumatic brain injuries and actually just treat the brain injury, within 3 to 6 months, the patient's hormone levels are back to normal. I've had a patient who was ready to have a kid. He had a very severe injury, and his testosterone, it took a little while, it took about a year, but it bounced back to normal. So we didn't have to give him exogenous testosterone. Hormones and TBI, like I said, you can start with healing the brain with multimodal protocols, which I'll tell about. I am also a big fan of supplements versus just going down the route of using hormones directly. So I like supplements that boost testosterone, as well as HGH. I've got a good couple of those. I recommend you contact me after the lecture if you'd like to learn more. And then glandulars, there's glandular products that you can use to improve this: hypothalamus, pituitary, adrenal glands. There's even testicular extracts from cows that are very helpful, as well as like thyroid glandulars. So looking at all these are important supplements that can improve the long-term benefits of hormonal outcomes with traumatic brain injury. So, and then there's the hormone therapy. So you go down that route if you want to. Also consider, helping these patients, especially older patients that have had brain injuries for a long time where their hormones have been suppressed. Newer, younger patients can often bounce back with the glandular products or herbs or other things that boost their hormones naturally. The older patients that have had brain injuries for a long time or dementia, it's a little harder to repair. Next thing is just talk about mainstream treatments, occupational and physical rehab, speech therapy, pharmaceutical drugs, cognitive maintenance exercises. Patients are often simply resigned to cope with their conditions. None of these treatments actually do much. I mean, there's no real drug for traumatic brain injury. Speech therapy, yeah, that's great, but all that's just trying to help improve what I would call the software of the brain and help the patient get to some stable, ability to eat or speak or something like that or move appropriately. And patients' brains can relearn, but if your brain's pretty injured, it's kind of like having a computer, not to overuse this analogy, but there's damage. If you try to run too many hard programs, you try to run Windows 10 on a 386, it's just not going to work. So we've got to upgrade that computer first to get it to a level of the hardware and the motherboard and the processor up to a level where it can handle new programs or even old programs that are running at a high level. So alternative treatments even are out there. There's a plethora of those. I mean, you name it. Somebody's hawking some kind of treatment that potentially can help. And that there's a lot of benefits with those, whether it's a supplement or it's a special diet or some other functional medicine. However, these don't always really regenerate. They can be kind of green allopathy, and they end up just treating the symptoms. And the other thing is, it's in my humble opinion and clinical experience, if you don't combine these regenerative treatments in a multimodal fashion, you're never going to get the patient outcomes that can really regenerate and produce long-term results. So it's been hypothesized that the multimodal effective combination of a practical effective combination of multiple regenerative TBI therapies can produce synergistic benefits to the patient that exceed the use of one particular TBI treatment. These include hyperbaric oxygen therapy, or even just oxygen therapy, but hyperbaric oxygen is pressurized oxygen that stays in the system. It's concentrated oxygen. Intranasal therapies, which we'll talk about, IV nutrition, cranial osteopathy, we're all osteopaths here, diet and nutrition. Hyperbaric oxygen for traumatic brain injury allows the body to absorb 10 to 15 times its normal supply of oxygen. It stimulates the growth of tissue, bone, blood vessels, and reduces inflammation. Here's the scan of a patient baseline, a pre-scan before they did hyperbaric, 50-year-old woman. And she had a traumatic brain injury that occurred 2 years prior to the study. After the treatment, you can definitely see improvements in perfusion over time, as in all areas of her brain. TBI also increases neuroplasticity, tissue oxygenation, generates new capillary networks, restores blood supply, and also increases stem cells. 2 hours of hyperbaric oxygen triples the patient's own circulating stem cells. And this is at 2 atmospheres. 20 sessions of hyperbaric oxygen increases circulating stem cells 8-fold, so 800%. So you're getting a lot of stem cells floating around. This is just a graph. It's CD34 positive cells. They are looking at what's called cells that are hematopoietic, as well as very small embryonic like stem cells in the body. They're in everybody's blood. They're all CD34 positive. So we can see what happens with this graph of the stem cell patients over time. What else is oxygen? Even if you just inhale some oxygen, you start increasing the amount of serotonin in the body. You can inhale oxygen. They did a study here of patients. It took only 6 people, but it was a small study, but it was good enough to show us something was happening. Three of these patients breathed at 15% oxygen, and 3 of them breathed a 60% oxygen mixture, and then they injected tracer, and they did PET scans afterwards. And what they found was you had very highly significant increases in the amount of serotonin available to the body and the brain. So serotonin synthesis were at 223 for the study group, and then for the control, the 15% group was much lower at 77, so significantly higher. Serotonin is increased by oxygen. Conclusions here: increasing blood oxygen increases 5-HT synthesis in the brain. Tryptophan hydroxylase 2 is not saturated with oxygen in the brain. Take home, you can breathe inhaled oxygen and increase serotonin. Anybody ever goes to the emergency, what do? They give patients a high level of oxygen and usually through a nasal cannula. And what happens is that most patients just relax a little more. So it's one of those things we see on a daily basis, even not even knowing what the whole biochemistry is. But largely we believe that serotonin is responsible when patients get hyperbaric oxygen or increased blood oxygen, even through inhaled oxygen. Regarding stem cells, hyperbaric oxygen is the safest way clinically to increase stem cell circulation, far safer than any pharmaceutical options. In the United States, we cannot grow up stem cells outside the body. They have to all be used within 24 hours of removing it from the patient's own tissues. And what we know is instead of growing stem cells up exogenously, we can simply increase the cells through hyperbaric oxygen. Intranasal therapies: insulin, PRP, and stem cells for TBI. So if any of us can smell something, we're not going through our bloodstream to smell something. You smell a chemical, it gets up into your nose and it goes right into your brain. There's a bug called Naegleria that can do the same thing if you swim in a dirty lake. It bypasses the blood-brain barrier, and you can get into the CSF within 10 minutes. You can spray that up there. You can also have the patient literally just lay back, and as long as you get the solutions up into the olfactory nerve area, the upper third of the nose, these solutions can go straight into the brain. It's the intranasal delivery, and it's been studied over many, many years, primarily with intranasal insulin, which has been used for Alzheimer's patients. And there's big NIH studies that were done in the early 2000s to prove this. The mouse brain, we've talked about the potential pathways of how the intranasal solutions can get into the brain: olfactory route or the trigeminal route. We've considered that the trigeminal route is much less likely. It's much more likely that most solutions are getting through the olfactory route. Intranasal insulin, as I spoke about, big NIH studies, they proved that this intranasal insulin can improve brain ATP production, decrease CSF cortisol, increase the neuronal viability in the hippocampus, lower the anti-inflammatory microglia, and reduce ultimately beta amyloid and tau protein deposition. So intranasal insulin has great long-term effects for patients with lots of amyloid, including Alzheimer's and dementia type patients, as well as helping prevent that in TBI patients. And this is just a graph showing that the neuronal viability, these are cells that were stained with a special stain that light up a little more, these neurons, when they were treated with insulin. And you also can see less inflammatory microglia in the hippocampus. Platelet-rich plasma. What is this? It's plasma that comes directly from everybody's blood. You spin out the red blood cells, and you can have what's called PRP. You can also just take all the plasma and take the PRP and the PPP. I normally just refer to all the plasma as PRP, even though the official way of talking about that is just lower fraction of plasma when you spin it out in a centrifuge. What do you have in platelet-rich plasma? You have all kinds of growth factors. There's over 300 of them. But a couple of them down below is one called VEGF and EGF. Those increase angiogenesis. There's PDGF, TGF dash P, which enhances collagen growth, and IGF-1, which stimulates protein synthesis. All of these things are amazing growth factors. If we can put them in the brain, they might actually do some amazing things as well. You can have an exponential increase in growth factors at the site of infusion. Once you put these in, the PRP actually has something called cytokines that control inflammatory mediators and actually guide those other growth factors as well as stem cells to areas of injury. What we know is basic fibroblast growth factor infusion enhances injury-induced cell proliferation, odontate gyrus, and improves cognitive function in rats following fluid percussive injury. So you can throw this, just even fibroblastic growth factor, to enhance basically the cognitive function in rats. And we also know that you can throw in VEGF or another, infusion of another growth factor called S100B or beta, and enhance neurogenesis in the hippocampus. So we know that if you throw these growth factors either from PRP or you isolate them, put them into the brain, and they can have long-term improvements in animals. So peripheral blood-based adult stem cells, as I discussed before, these are CD34 positive cells. They're pluripotent adult stem cells, and they can behave just like embryonic stem cells and give rise to any cell type, and work great in combination with platelet-rich plasma. They have regenerative and reparative properties, and we haven't done a lot of studies on these cells yet, as far as in the brain, but we do know that the cells, even from bone marrow, can treat ischemic brain damage. And ultimately, what we see is a downregulated of neuroinflammatory cytokines. Other intranasal nutrients include, substances include glutathione, which has been done intranasally to reduce oxidative stress and enhance cellular detoxification in Parkinson's disease patients. I've actually used intranasal glutathione with patients going through detox from a variety of different drugs or things like heavy metals. Like I used it regularly with a patient with aluminum poisoning. You can also use intranasal methylcobalamin to improve theta activity on the QEEG. So we've seen that work well with autism and ADHD patients. Intravenous nutrition. So if we're trying to give a metabolic benefit, what do we need to do? We need to improve the nutrition for brain injury patients. We need to improve the metabolic aspect, because that's what's going to drive good metabolic activity. So we can use PRP as an IV. So we can add that back to the IV. We can add stem cells back in. We can use NAD+. This is one of my favorites. NAD+ is one of the last precursors to the brain, or anywhere in the body, the mitochondria, anywhere in the brain or in the body, making energy. And then you throw in some magnesium, calcium, potassium, B6, B12. Ideally, a cocktail with much more magnesium is what I use, just a very small amount of calcium. And all those things tend to either improve the oxidative ability or the oxidative potential, so that, the resistance of the patient's cells to being destroyed oxidatively, and also B complex, B5, B12, B6, all those are cofactors to making energy, to making metabolic activity happen better and quicker. Cranial osteopathy for TBI, we're great osteopaths. What do we want to do? Improve CSF flow overall with manipulating and balance that CSF flow. So we manipulate the skull bones. And this is what happens. You move the cranial bones and membranes to allow the cerebrospinal fluid to flow more properly. The central nervous system has a very subtle rhythmic pulsation, also known as the cranial rhythmic impulse. If this cranial rhythmic impulse gets blocked, say there's a dam in the river of going up and down the spine, or a dam in some part of the brain, then we ultimately can impede blood flow and CSF flow, which can ultimately lead to waste products building up, nutrition unable to get to certain areas of the brain. Treating vertigo and headaches, or even oxygen getting to certain areas of the brain. Treating vertigo and headaches associated with TBIs has been successfully seen with cranial osteopathy. It's a very unique shift. This is transcranial Doppler, is what this stands for. And they're looking here at the time shift of transcranial Doppler with the impedance. What we see with a healthy person is a certain wave, this certain T value with an athlete, the same thing. This wave basically, where the peaks are in these waves with the beta impedance as well as the transcranial Doppler, basically determines how effective and how big of a cranial rhythmic impulse a patient has. What you see with a patient with a brain injury, this T value is that cranial rhythmic wave going through their brain is much lower. So the cranial movement is subdued. Viola Fryman years ago said that when you look at a brain injury patient, their head might feel like a brick. And that's exactly what you feel is you just don't have much of that impulse. And you can see that the CSF, the mobility of the CSF is not very active with traumatic brain injury patients until they get treated. And I can actually sometimes even feel once we treat these patients with intranasal therapies or hyperbaric treatments that their cranial rhythmic impulse improves rapidly. Nutrition for TBI, ketogenic diet, basically a high fat, low carbohydrate, adequate amount of protein. This is not a Atkins diet. This is a higher fat diet. We want to improve fats, which ultimately improve the amount of GABA in the system, which lowers oxidative stress. You throw in glucose, carbohydrates. It's like simple sugars. It's like having kindling on a fire, or gasoline on a fire. It burns up and then it goes back down. It kind of goes through these cycles. You have to keep adding it to keep it burning. It doesn't ever get really that kind of like steady heat. You throw ketones or fats or something like a log, which burns slower and a little longer, and then you have a much better, longer lasting fire. And that's what you want in your brain. Ketones, in another analogy, are like diesel fuel. Glucose is like gasoline. Diesel fuel has a much higher flash point than gasoline, which means it's harder for it to like vaporize and kind of blow up and burn up. It's much harder to oxidize. It's less flammable, less excitable, and the brain does much better on ketones than it does on lots of simple sugars. Everybody's brain burns sugar as its primary resource. However, if you can modulate the sugar it burns with ketones, then it's burn much more efficiently. So much more efficiently, and it's going to last longer, and it's going to help the patient out a lot longer. So the other thing that a ketogenic diet or ketogenic fuels do is it increases GABA, like I said, increases the calming in the brain, and ultimately gives you more neuroprotection by decreasing inflammatory neurotransmitters like glutamate, and can lower depression, fear, and anxiety. Ketogenic diets have long been used in medicine, especially for patients with seizures. And if we can reduce that oxidative stress and produce this brainstorm that occurs with seizures or TBI, for example, then we have a much better chance of helping the patient heal. This is just a little graph over here and kind of how it's the GABA is acting to kind of affect glutamate receptors and channels. And this is partly why we have anti-convulsive effects of the ketone bodies in the brain. You also have increased membrane potential with the hyperpolarization, and this isn't that important here, but and decreased reactive oxygen species. So you're ultimately reducing oxidative stress and improving electron transport chain, which ultimately leads to more ATP. So summing this all up, you have more ATP, less glutamate toxicity, more mitochondrial biosynthesis, and more energy metabolism genes at a much lower energy requirement, or at least simple energy requirement. So the other thing is we've kind of learned over the years is that you you need to have some, you can do a ketogenic diet for a little bit, and that's great for balancing and calming the brain. But longer term, it's important to improve serotonin levels by enhancing some carb ingestion. So a lot of my patients, I put them on a modified keto diet. So I have them eat carbohydrates in the evening. Having a low carb helps release insulin into the bloodstream, and that accelerates the removal of these large amino acids that compete for the tryptophan receptor in there, such as valine, leucine, and isoleucine. Increasing protein also can slow its elevation, so a strictly paleo diet is not always the best either. However, tryptophan, as we know, is very common in turkey. So everybody that eats a big turkey dinner usually wants to fall asleep in the afternoon on Thanksgiving Day. So it's definitely a protein that does have a lot of tryptophan in it. Tryptophan's also in some other foods, oats, chocolate, bananas, things like that has a lot of tryptophan in it too. But what does tryptophan do? Tryptophan is the best, in some of the best ways to increase serotonin in the body. I'm more of a fan of tryptophan over the years than I am particularly 5-HTP, partly because you can take a lot more orally tryptophan than you can 5-HTP. Taking 5-HTP is not always the best at getting serotonin directly into the brain. The daily requirements, you can see that 5 milligrams per kilogram. Almost every adult consumes much more, usually 4 to 5 grams a day, which is 60 to 70 milligrams per kilogram. So ingesting what we have found, L-tryptophan raises tryptophan levels and stimulates its conversion to serotonin in neurons. The side effects, however, if you get too much of it, then you can start to get tremor, nausea, and dizziness. You can also take tryptophan as a supplement, which has been used for over 50 years now, mostly as a sleeping supplement. Just don't take tryptophan or any kind of 5-HTP supplement when a patient has any kind of SSRI on board. In general, SSRIs are contraindicated for TBI, can lead to higher suicidality as well. So avoid SSRIs in general for any patient, any mental health patient that might have had a TBI. Instead, replace that with tryptophan to see what they can do just with this natural supplement. Variations in tryptophan can be found due to 5-HT synthesis. 5-HT synthesis falls when tryptophan declines. I talked a little bit about other amino acids. That's why we give carbs. And if you get too many of these other amino acids, isoleucine, valine, the large neutral amino acids, then you can block tryptophan's absorption. So be careful with very high protein diets too. Microbes alter the availability of tryptophan. Their synthesis in the intestinal intrachromaffin cells, and then the microbes actually help stimulate that. They store it in platelets, and it gets released upon stimulation. So adding platelets to the brain can also help add tryptophan to the brain. So that's another benefit of the intranasal therapies, especially in combination with high oxygen therapies. It's estimated that these microbes make up to 90% of the serotonin in the digestive tract. So, and it's primarily made from tryptophan or tryptophan precursors. So, or tryptophan components. So it's pretty amazing that these types of microbes, how much effect they have on our brain chemistry. Microbes also produce short-chain fatty acids that, like butyrate, that influence production of serotonin. So ultimately, a take-home is healthy gut microbiome leads to serotonin increased levels. So the multimodal protocol, this is day 1. We will do cranial osteopathy, hyperbaric oxygen, IV PRP and nutrition, IN PRP and nutrition, intranasal. And then day 2, and we've actually been able to combine this all into one day as well. But usually we have it done over 2 days. all within one 24-hour period. But we'll do IV pluripotent stem cells from the blood plus NAD plus, as well as intranasal pluripotent stem cells from the blood. Now, keep in mind, these are not compounded or manipulated in any way. These are isolated cells. There's no manufacture of them. And then we use hyperbaric oxygen again after the treatment. We have patients who can get to a medical hyperbaric oxygen treatment, and we'd like to sandwich the stem cells and the PRP in between those treatments, so they get 10 to 20 treatments before and after the PRP or stem cell infusions. And if they can't get a medical grade hyperbaric chamber or to a medical grade facility, then we send them a home hyperbaric chamber, and that home chamber is FDA approved. Patients use it 5 to 7 days a week, at least a month before treatment, and then for 2 to 9 months, 5 to 7 weeks after the treatment. Usually I like to let patients after 4 months after we've treated them to go down to 3 to 4 days a week. Most patients just want to keep using it. It's so helpful for their brain. What we've seen, 46-year-old male, before the treatment, the patient has memory loss, headaches, emotionally unstable, depression, anxiety, couldn't drive, has insomnia. After treatment, he had a memory download, an awakening, mood and personality improvements, ability to read, ability to turn on lights and electronics. He's able to drive. He now actually has a farm, and he has a great job and is getting married. His case report, it was like a stream of information had been let loose. I felt for the first time in a year that had some clarity. I was excited to read more than 2 or 3 sentences without triggering a migraine. The ability to think and plan returned. Case 2, 30-year-old female, before treatment had insomnia, mood swings, depression, unable to work, head pressure, sound and light sensitivity, able to travel to work after treatment, light and sound sensitivity decreased, improved mood, less fatigue. It felt well enough that I started saying yes again. TBI therapy turned me into a TBI thriver, not just survivor. I'm happy, enjoy life again, and can travel and doing more work in the world that's aligned with myself than ever. Case 3, 48-year-old female, before treatment, anger, depression, suicide ideation, anosmia, which is loss of smell, extreme mental fatigue, and PTSD. After treatment, she's calm, no longer reactive and irritable, confident, no feelings of suicide, less inflammation, improved memory, improved sense of smell. Results for me have been nothing short of miraculous. Poppy may have his spinach, but I have stem cells and PRP. Yes, my brain is strong. At over 100 patients we've treated, and actually probably more like 400 or more over the past 7 years, we've seen more mental clarity, improved memory, more stable emotions, better ability to cope with pain, more physical and mental energy, improved decision making as well. For some patients, light and sound sensitivity improves, improved eyesight even, improved sleep and libido, improved motor function, and less muscle spasticity. Conclusion, the multimodal regenerative approach is a superior way to treat traumatic brain injury. And the practical, effective combination of these multiple regenerative TBI therapies can produce synergistic benefits to the patient superior to mainstream TBI or single modality alternative or mainstream treatments. Thank you very much for this time to speak. I'm honored. Again, my name is Dr. John Hughes. Feel free to contact me at any time about more about these treatments.